consumed in excess.
All right, and let's take that and break it down a little bit. What's a central nervous system depressant? And then what do you mean when taken to excess? And is there like different effects that ethanol has before this magic excess?
The central nervous system is the CNS, and that pertains to our brain primarily. So in toxicology, the field of toxicology that I practice, mostly pertains to drugs that act on the brain or the central nervous system. As a depressant, it means it depresses the central nervous system in comparison to a drug that might stimulate the central nervous system. So depression means you might see slowed responses or lethargy, slowed heart rate, lowered heart rate, blood pressure as well, compared to something that might stimulate the body.
And was there a reported ethanol value or drinking alcohol value for Mrs. Ward's blood that you relied upon before giving some opinion testimony we're going to get to?
Yes, when her blood was tested by the toxicology laboratory, ethanol or alcohol was detected.
And at what level in the blood?
The concentration is 0.133 grams per 100 milliliters. So that's commonly known as like 0.11.
All right, you said 0.133 and then you said 0.11. Did you mean 0.113?
0.113.
Okay. And how does that relate, if you're familiar with the established standard of alcohol level for a DUI in the state of Florida, and I guess in most states?
Yeah, actually in all states, the DUI limit is 0.08, so this is above the 0.08 limit.
All right, and did they test any of her eye fluid as well?
Yes, in post-mortem examinations, eye fluid, it's known as vitreous humor, would be collected, and it's a second sample that would be tested for alcohol as well, and the concentration of alcohol in the vitreous was 0.110.
All right, now what, if anything, can you tell us as a forensic toxicologist about the relationship of those two numbers from those two different places?
So the concentration that we most rely on in terms of effective alcohol in the body would be the blood alcohol concentration. The vitreous is a sample that's run primarily for confirmatory purposes, make sure that there wasn't a mistake in collecting the samples or analyzing the samples in the laboratory. So in this matter, we have a blood of 0.11, actually 0.113, and a vitreous of 0.110. They're essentially the same. So obviously there is confirmation in place to ensure that the results are correct. I really can't say any more with regards to what those values mean exactly.
Okay. It's just my understanding that sometimes when those numbers are grossly different, people can give opinions perhaps about how recently it was ingested and whether it was still on the uptake or the downtake. Am I offbeat on that?
Sometimes. So, and it gets a little bit complicated, so I'll just demonstrate it for you.
Reader's Digest version.
Yes, it will be quick. As the blood alcohol concentration increases, so does the vitreous, the eye fluid alcohol concentration, but it lags behind. It may lag behind in terms of time frame by a half hour, an hour. We don't really know exactly how long because you can't do studies in living people, of course. So as the blood alcohol concentration is increasing, the vitreous is following behind like a tail on a dog. There'll be a time where the alcohol concentration in the blood peaks and then it's going down. So the vitreous continues to follow behind. So when alcohol is being absorbed in the body, the vitreous falls below the blood typically. And when all the alcohol has been absorbed, then the vitreous is falling behind like this, but it's higher. In this case, we have 0.11 and 0.11, so it's about the same. So it's somewhat difficult to say exactly where she was in terms of absorption and elimination of alcohol.
Is it fair to say that 3,000th of a gram per deciliter is 3,000ths of a gram per deciliter, or 100 milliliters, right?
Yes.
Relatively plateaued?
Yes.
Okay.
They're the same.
Now, can a forensic toxicologist or a medical pathologist or anybody say, based on somebody's blood alcohol level alone, what particular behaviors or effects a particular person would be under from that alcohol?
No, there's a continuum of effect in a person, and that continuum in each and every one of us is different. So the way that I react to alcohol will be different than the way that you react to alcohol. So while we can say that Ms. Ward's normal faculties were impaired by alcohol at the time of her death, we can't say exactly what and how those faculties were impaired. Were they impaired to only a small degree or moderate or significant degree? Can't really say.
And can one, through continuous and repeated use of a substance like ethanol, build any sort of tolerance to the ethanol?
Yes, and that's one reason, a physiologic or pharmacologic reason for why we can't tell you exactly what the effects were at that moment, unless, of course, they were recorded one way or another, because an individual will obtain tolerance to the substance. So in this case, if there was repeated ingestion of alcohol over a period of time, she may be tolerant or acclimated to the effects of the alcohol. Doesn't mean that her faculties are not impaired. So pharmacologically and behaviorally, she is impaired, but maybe not as impaired as someone who has no tolerance.
Okay. But regardless of the inability to say with any specificity what any particular person at any particular place and time would be feeling from the effects of ethanol, it is a central nervous system depressant.
Yes.
And does that affect one's gross motor skills and coordination?
Yes, and that would include the ability to walk or even talk.
And isn't that even like in the jury instructions for a DUI, the normal faculties of talk, walk, make decisions, do ordinary daily things?
Yes.
How about fine motor skills, like things that require your hands?
Those can also be affected at higher concentration of alcohol. Again, in this case, I can't say for sure, unless, of course, there was some sort of recording. Like in a DUI, we would have field sobriety exercises that might be recorded, so you could see and evaluate that. Of course, we don't have this in this matter.
Okay. And balance?
Yes, balance.
Okay. Let's talk about a substance called Trazodone. Are you familiar with that particular substance?
Yes.
And what is that particular substance?
Trazodone is an old-fashioned antidepressant medication. So 30, 40 years ago was used as an antidepressant. It's more commonly used today as a sedative or sleep aid. That's one of its side effects, is it makes you sleepy. It helps you sleep.
And what particular class of drug is this drug?
Well, technically it's an antidepressant, but it's also a sedative.
All right. And how does an antidepressant work, like Trazodone, that particular antidepressant?
All antidepressants work in the central nervous system. Again, we're speaking to the brain. So it has an effect on neurotransmitter levels. So the Trazodone drug, which is, as I said before, has been around for decades, was used as an antidepressant, but its side effect is to be sleepy. It has other side effects, particularly when too much is consumed. So it's fairly easy to overdose on Trazodone. It's not a drug that's prescribed today to treat depression. There are better drugs and more safe drugs than Trazodone.
Is it still continue to be prescribed for what we call like not the intended manufactured use?
For sleep, yes.
Okay. And was there any Trazodone found in the toxicology report for Mrs. Ward?
Yes, there was.
And at what level?
The concentration is 0.082 micrograms per milliliter.
And in the world of toxicology and forensic toxicology and the practice of medicine, has anybody developed like a therapeutic range for this drug Trazodone?
Yes, there is a therapeutic range. Now, when you refer to a therapeutic range,
Please explain that.
yeah, that's a therapeutic range or range of blood drug concentration that causes a therapeutic response in the individual. These therapeutic concentration ranges don't necessarily correlate to what you would find in a post-mortem. I think we'll talk about that later. So we have to be careful when we apply therapeutic ranges that are designed for interpretation of blood drug concentrations in living people compared to someone who is deceased. But we do have a living therapeutic blood drug concentration for Trazodone.
All right, and her level, where does that fall within the living person therapeutic range for Trazodone?
Well below the therapeutic concentration range.
And
Just remember that's in a deceased blood sample versus in a living person. But it's a concentration that I would expect to have almost no effect.
Okay. And I was just going to ask you, with this drug, Trazodone, is there any particular way for you or anybody else, like a medical doctor, to say what side effects, if any, that particular person or intended effects would have been under from the Trazodone?
Well, based on my decades experience in the field and assessment of Trazodone in hundreds of decedents, I would say this has no effect.
Okay.
And this may be consistent with taking Trazodone the night before, and this is what's left over as a residual the following day.
And so hypothetically, if her time of death was around 7:50, 7:55 p.m., I know you just mentioned perhaps taking it the night before. With that more narrow time frame, does that fit with what you just answered?
Potentially, yes.
Okay. Now, you were talking about how some classes of drugs, there may be a different level post-mortem, which is after death, versus ante-mortem living. Is Trazodone one of those such drugs?
Yes. Each and every drug has the potential to change during the post-mortem interval. That's the interval from that instant of death to the time of autopsy. So that because of that potential post-mortem change, we have to interpret blood drug concentrations with great caution. As I mentioned before, we have a therapeutic concentration range for Trazodone, but it doesn't really apply to a decedent, certainly not in a vacuum. So you can't just look at the concentration and say, aha, that is the cause of death. Now, there are circumstances where blood drug concentrations are very high, and then we can clearly assume that that is the cause of death. But when the concentrations fall within these typical concentration ranges for a post-mortem, they're not necessarily or immediately to be assumed to be a cause of death, or even to have any real effect on the individual's behavior or performance.
And what is the physical mechanism that is going on in a body to cause this post-mortem redistribution of a drug such as Trazodone?
So there are many possible mechanisms of post-mortem drug redistribution. That is the movement of drug to and from tissue, to and from the blood vessels, to and from muscle. So even to and from the stomach, if there's drug in the stomach or the GI tract. So part of the mechanism is easy to understand because we learn about this in high school, diffusion. So concentration goes from high to low, and the drug that's in the blood will migrate from high to low. So if you have a tissue or a vessel where there's high drug concentration, it may transfer through the tissue, through membranes, to someplace that's low until there's some sort of equilibrium there. That's fairly easy to understand. We also know that some drug has particular affinity to specific tissue in the body. So we know that some drugs have a high affinity for cardiac tissue in the heart. So these are just two of many possibilities that cause redistribution of drug. So in the end, really, the interpretation of a blood drug concentration has to be interpreted with great caution.
And does it matter where the blood sample is drawn from that is being tested to talk about this issue of post-mortem redistribution?
Yes, generally, but again, there's not a hard and fast rule to say one is definitely better than the other. We prefer blood samples that are collected from the periphery, as far away from the chest and even the abdomen. So blood collected from the femoral artery or vein, or blood collected in the arm from the subclavian are ideal. In some postmortems, that's not possible, but when possible, that's the best sample, least subject to redistribution because it's furthest away from the drug depot that's in the central compartment of the body.
And in this particular case, if hypothetically her post-mortem blood sample that was sent to the lab was drawn from her femoral artery up near her bikini line, is that considered peripheral?
Femoral artery blood is peripheral.
And in peripheral blood, is this phenomenon of post-mortem redistribution completely absent, or what can you say about that issue?
It's not absent. So there's no way, unfortunately, to freeze the body as is at the moment of death and prior to the autopsy. So these changes occur, and they occur with great frequency, and there's no possible way to measure it. So I can't extrapolate backwards in time to the time of death based on a blood-drug concentration from the femoral artery, for example, in this case. So again, caution is advised.
And I know you said that the Trazodone levels in this case were pretty insignificant to the point that you could opine that there was no effect on behavior. But hypothetically, if there was, is there any relationship between ethanol and Trazodone? Would they be like an additive effect that add on to each other? Or would they subtract from each other, or something else? Can you explain?
Something like additive, but it's not possible to do 1 + 1 is 2. But alcohol is a central nervous system depressant, and as I said, the Trazodone is a central nervous system depressant as well. So you might have the combined effects of the two. Whether it's exactly additive or more than additive, I can't really say.
Okay. Now let's talk about citalopram. Are you familiar with that substance?
Yes.
And I believe that it comes under a couple different brand names, but are you familiar with a brand name variety of it called Celexa?
Yes.
All right, what can you tell the jury about this substance, citalopram, that comes in the form of Celexa?
Citalopram is also an antidepressant, so the effect on the body is similar to Trazodone, but it is more effective, but it's also more safe. So the newer generation antidepressant drugs that were introduced 20 and 30 years ago, these are called serotonin reuptake inhibitors drugs, or SSRIs. They are more safe, it's more difficult to overdose with these drugs, but you still have the antidepressant effect.
And just briefly, what is serotonin and what is SSRI?
Yeah, so it's a selective serotonin reuptake inhibitor, SSRI. Serotonin is that neurotransmitter in the brain that makes us feel good. We're less depressed if you have normal levels of serotonin.
And so how does this drug work to make people who are less happy more happy?
Because it stops the reuptake of the serotonin in the brain, in the nerve system, in here.
All right. So for me, Friday is my day to take the garbage and the recycling bins out. So are you saying that our body has this process where you have serotonin and it needs to get taken out to the curb every so often, so to speak? Is it something like that?
Well, there's a constant process of production of serotonin and a turnover and reuptake of the serotonin in the neurotransmitter system. So what this drug is, it slows down or prevents the reuptake of the serotonin, so you end up with increased serotonin in the brain, and therefore less depressed. That's the goal.
Okay. And besides being used as an antidepressant to treat depression, which is a sad mood, right?
Yes.
Does it have any other uses?
Not really. Citalopram is principally an antidepressant drug. Some physicians may use it to stabilize mood, so maybe it's not necessarily a depressant type mood, but it could be used or maybe termed as a mood stabilizer. It may also be used in a patient who's being treated for anxiety, but it is, by definition, an antidepressant drug.
All right. And in the blood sample that was drawn from Mrs. Ward and sent off to the toxicology lab, was there a reported value for citalopram in that blood sample?
Yes.
And what was that level according to the lab?
840 nanograms per milliliter.
And just really quickly, what's a nanogram? How does that relate to grams, micrograms, and then is it milligrams? as we go down?
Milligrams, then micrograms, nanograms. It's a figure. You can't see a nanogram, but we can measure a nanogram. We can even measure a picogram, which is smaller than a nanogram. We have very good sensitive instrumentation to be able to measure down that low.
Okay. Now, same question as I asked earlier about Trazodone. In the world of toxicology and forensic toxicology and practice of medicine, has there become an accepted range for a therapeutic value for somebody who's alive taking citalopram?
Yes, there is.
And what is that range?
The range in living persons is 9 to 200 nanograms per milliliter.
All right, so let's talk about that. 840 is more than 4 times, almost 4.5 times 200 nanograms. Is there any post-mortem redistribution phenomenon with this substance as you previously described with Trazodone?
Yes. So citalopram is a drug that will redistribute.
And when a blood sample is taken from the femoral artery, is that phenomenon of post-mortem redistribution still a possible thing?
Yes, every time.
So how about taking it from the heart as opposed to the femoral artery? Can you discuss that, compare and contrast?
The likelihood of redistribution, if you have a specimen from the heart, is greater than if you have a specimen from the femoral artery, in most cases. But there are cases where the femoral is more likely to redistribute than the heart. So there's no hard and fast rule about redistribution and how to predict what that ante-mortem before death blood drug concentration was. That's again why there has to be great caution, particularly in individuals who are taking a drug for a long time. So if an individual is taking a drug like citalopram to treat depression for months or even years, there begins to be a depot, meaning a collection of or deposit of drug in the body and all throughout the body. So that increases the likelihood of redistribution.
If somebody had been prescribed citalopram for approximately 50 months prior to their passing, I guess that's improper grammar, his or her passing, would that 50-month time frame be what you're talking about?
Yes, that's more than 4 years.
And so when you talk about it builds up, where does it build up in the body?
It's stored in the tissue, so in the muscle, in the organs, in the vessels, in the blood. And it's not that the individual is going to become toxic because of it. Certainly they do become tolerant to the drug, and that's why when individuals begin to take this drug or other drugs, you start with a small dose and you increase and escalate the dose until you have a therapeutic effect. But repeated administration of a drug leads to accumulation of the drug in the body, and it will take days or weeks to rid the body of all of that drug.
Now, you said earlier that there's some tissues with some drugs that there's certain parts of the body that they favor to be stored in. Is there any sort of that phenomenon with citalopram?
Not that I'm aware of.
All right. And so, hypothetically, if 840 nanograms per milliliter were ante-mortem value, is that considered toxic?
I would be concerned.
All right. And tell us about your concern.
Well, it's higher than therapeutic in a living person, and I emphasize the term living person. What those effects might be, hard to say. Citalopram is a very safe medication. It would be very difficult to overdose and die as a result of consuming even an entire bottle of citalopram, unless it was a 90-day supply, for example, and then that would be possible. But if it's a smaller quantity of citalopram, there may be some side effect, some sedation, for example, or lethargy that's associated with the overdose.
Can you tell us, break down sedation and lethargy?
So,
what does that mean?
Yes. Sedation is just, in my opinion, is someone who just feels sleepy, maybe after a long day, or even after a few drinks. You feel a little bit sleepy and slow. Lethargy is in my opinion, kind of a physiologic change in the body where the individual is sluggish, their ability to respond to stimuli is affected in a negative way. It's the precursor to a drug-induced coma, from sedation, lethargy to coma.
All right, now let's talk about citalopram's effects. I assume before the FDA allows people to sell citalopram that there's studies run. Is that fair to say?
Yes, the FDA will conduct phase 1, phase 2, and phase 3 trials. And during those trials, there will be individuals who have ill effects or even attempt to overdose on these medications, particularly when you speak about an antidepressant drug. And people who are depressed, their likelihood to attempt a suicide is greater than in someone who's not depressed. So there would be cases in the literature or even described in the package insert about these individuals and their outcome.
All right, so we'll get to that. Now, again, with the caveat or warning that you, a doctor, nobody can really say what the particular effects or side effects any particular person would be experiencing at any particular time. Based on these studies that they've done on citalopram, what are some of the effects that one can observe, generally speaking, in this population study of people that are taking it at the prescribed level that they're hoping to sell?
At the prescribed level, or?
Yes, we'll start with the prescribed level.
Yeah. Very little side effect. It's very well tolerated. We do know when you begin to take medications that are acting on the central nervous system, you have to be very careful about operating your motor vehicle, for example, or working, or if you operate heavy machinery at work. So you need to be careful about that, at least for a few days. But citalopram is a drug that's tolerated very well by many people. And it's a drug that is really not very toxic.
And did these studies show that it had any intended effect of making people seem more happy?
Yeah, I'm not sure I would
Well,
use
less
that.
depressed, I mean.
Yes, less
Stellar.
depressed, and the mood is stabilized.
Okay.
Yes.
Now let's start talking about, as you take more than is intended, what are the side effects that can be seen in people, although you can't say it was in any particular person?
The most common side effects are sedation and the lethargy, and it could lead to death, of course, if too much of it is ingested. But even those side effects are typically not lethal. So people who ingest too much citalopram recover.
And are there any other side effects such as hostility, aggression, irritability, hallucinations?
There can be. There's some rare reports of that in the literature.
That's what I was going to ask you about, is the frequency of those as compared to the lethargy and sedation.
I would say the frequency is less than just this feeling of sleepiness or lethargy.
And as we get closer and closer to a level of citalopram that might kill you, and correct me if I'm wrong, it might cause respiratory stopping. Is that how it kills you if you take too much?
Yes, you'd fall into a coma. There would be depressed physiologic function, so loss of respiration, hypoxia, anoxic injury to the brain, and death.
And as we get closer to that level, is there any change in the frequency or the list of side effects that we've been discussing as you get closer to the toxic level?
Well, those physiologic changes, obviously, that result in death. But again, it's still primarily a depressant on the central nervous system.
Okay. Now, you mentioned something about injury to the brain. What are you talking about? How does that occur by taking too much citalopram?
If you have loss of respiration, you're not breathing, then the blood no longer carries oxygen. So there's a hypoxic injury to the brain. That's when it's starved of oxygen, and then anoxic injury, which is then typically lethal.
Are you familiar with excuse me, a term called edema?
Yes.
And what is that? Can you tell everybody?
Edema is swelling. You can have edema in a variety of organs, including the brain.
Can citalopram cause edema or swelling of the brain if it's taken at a certain amount?
If an individual overdoses from citalopram and the progression of the overdose is slowed, which it typically would be, it wouldn't be like an instant death like you might see in an opioid overdose. An individual will fall unconscious and slowly die through this progression. Then you do see swelling of the brain.
And is there ever any nausea or vomiting attributed to this path towards taking too much citalopram?
Only early on, and that's just simply by the nature of introduction of too much drug into the stomach. You, of course, become nauseous. And that's true with many drugs, aspirin or Tylenol or naproxen or other prescription drugs. If you insult the stomach with all of this drug, this chemical, you do become nauseous and you might vomit.
If someone were to attribute edema or swelling of the brain, injury to the brain, to citalopram, what other phenomenon would you expect to be able to have observed in that person?
You also likely see pulmonary edema, which is fluid in the lungs, either grossly or under the microscope.
How about behaviors people without microscopes and slides can see?
What might you see? Well, the individual would be unconscious. When the brain swells and becomes edematous, the person is unconscious. It's not consistent with life.
Okay. Now, let's talk about the relationship, if any, between citalopram and ethanol. Is there any relationship, and what can you say about this?
I would say very little once the individual is acclimated to the effects of citalopram. So I'm sure of all the hundreds of thousands or millions of people that take citalopram every day, many of those people are drinking alcohol as well. Now, while you need to be cautious, just to be smart about how much alcohol you consume and the prescription drugs you take, the effect, I would say, is minimal. Of course, you have the effect of the alcohol, but that citalopram doesn't really contribute much to the sedative or central nervous system depressant effect of the alcohol. This is in comparison to the Trazodone, because we know Trazodone is a sedative. In this case, this citalopram doesn't act as a sedative.
What if we were to dial up the citalopram from the therapeutic 9 to 200 nanograms per milliliter up to 840 nanograms per milliliter, in addition to 0.11 grams per deciliter of ethanol, with, again, the caveat that nobody can state what any one particular person would be under, the effects they'd be under. What could you generally speak about with that?
Generally, I would expect to see increased depression of the central nervous system, so more likelihood for feeling sleepy and lethargic, probably less likely to be able to walk straight, and maybe the individual might stumble.
How about fine motor skills that involve the use of the hands?
You would likely lose that.
Would you expect hostility, aggression, hallucinations, those sorts of things when the citalopram is dialed up to the 840 nanograms range coupled with 0.11 ethanol?
I think the frequency of that is very low. Anything's possible in the world.
Absolutely.
But I think the frequency of that is not likely. The predominant effect is going to be the central nervous system depressant effect, alcohol plus the drug. Agitation, I would say, is less likely to be present.
All right, now let's go through the process of how one takes some citalopram and it starts going into the tissue to hopefully have its intended effect of being an antidepressant. Take us through that process.
So citalopram is available for oral use only, so it be ingested as a tablet. Typically 20 milligram tablets. They may come in smaller tablets as well. So it would be ingested usually once or twice a day, orally, with some liquid, of course. Once it's in the stomach, it may be digested to some degree when it's exposed to the stomach acids, and then eventually it's going to pass through the pyloric sphincter into the small intestine, where the majority of the drug is going to be absorbed. Maybe a small fraction of the drug will be absorbed in the stomach, but most of the drug will be absorbed in the small intestine. So it takes time. I would refer to it as a transit time. if the stomach is empty or nearly empty, the transit time is quick, measured within minutes, like if you take Tylenol for a headache. It works within 15 minutes or so, 15 minutes to a half hour usually. If the stomach is full of food, the transit time is delayed because a drug gets mixed up with the food, and until the food is digested, it's not going to pass through the pyloric sphincter into small intestine. So it's just a matter of physics.
So hypothetically, if one's stomach contents at the time of autopsy is 10 milliliters of a pink fluid, would you consider that to be a full stomach of food?
No, that's an empty stomach, essentially.
And for those of us that are more familiar with, I guess it's called the imperial system of measurement, ounces, can you help us out with 10 milliliters?
Maybe a tablespoon or two. It's a very small amount of liquid.
All right. Now, given what you've said about how quickly it would pass through the empty stomach and down the pipes to where it's more readily absorbed, do you have an opinion as to whether or not examining the stomach contents of 10 milliliters of fluid during an autopsy would help you understand anything about the relationship of citalopram to either cause or manner of death or the person's behavior at the time of their death?
Yeah. In some instances, it can be helpful. In other instances, it's not. I think first you have to look at the stomach contents grossly, which is what the medical examiner will do, and it's described in the autopsy report as well. In this case, we have 10 milliliters of a pink-tinged liquid. So first and foremost, there's no evidence of tablets or even residue from the drug that's been digested. But we'll move on to the next is, what does the toxicology indicate? So in cases where toxicology is requested, and this is in my 30-plus years of experience as a toxicologist, in these cases, we may find no drug in the blood of an individual who clearly died of a drug overdose. It is helpful, and if we find nothing, we may go to the stomach contents and evaluate it to maybe we'll find something. It's sort of tissue or fluid of last resort. So that's one instance where it's helpful. In another instance, the medical examiner may want to know the approximate dosage of drug that was ingested by the individual so they can discriminate between an accidental drug overdose, not on purpose, or a suicidal drug overdose, which is on purpose. Obviously, if it's an on-purpose overdose, the individual might consume an entire bottle of medication versus accidental, maybe 2 or 3 extra tablets because the pain was really bad that day, as an example. So we can calculate the dose of a drug in the stomach, and the medical examiner can do further calculations to assess whether it's purposeful or not, or at least consistent with whether it's purposeful or not. So in my experience, those are the 2 main reasons to examine the stomach. We don't do it routinely at the university. We do it per request, and it's probably no more than a dozen times a year.
And so more narrowly, the relationship to trying to understand a person's behavior at the time of their death, what's the relationship and relevance of examining the stomach contents in this situation to trying to understand that?
Well, if the behavior is clearly indicative of a suicidal overdose, behavior might be left a suicide note or texted someone goodbye, then it could be quite useful. But routinely, I don't find it to be that useful.
How about bladder contents? When it comes to understanding the relationship between citalopram and cause and manner of death, or again, the hypothetical behavior of somebody at the time of their death, is there any relationship or utility of exploring the bladder contents?
No, not really at all. In this case, I don't believe the urine was tested. At Florida, we do routinely test urine when it's provided, in most cases. So it gives you an indication of what the individual had consumed or was exposed to previously, but it alone can't be used for determination of cause and manner of death because it's a waste product from our body. Our kidneys filter these exogenous or foreign substances from our blood into the urine. So these are just byproducts, metabolites, excess drug. So most often the amount that's in the urine is not a clear indicator of what's going to be in the blood. And you really can't rely on what's in the urine to make this cause and manner of death determination in most instances.
Or any relationship to the behavior at time of death?
Even more difficult, no.
All right, now how about, can a forensic toxicologist such as yourself opine, give an opinion about how many 20 milligram citalopram pills it would take to put somebody at 840 nanograms per milliliter while they're alive? Is there any way to do that?
No, so I talked a fair amount about post-mortem drug redistribution, and because of the likelihood of this redistribution or change in blood drug concentration, we cannot calculate dose of drug when given a blood drug concentration. You can do that in a living person if you have enough information, but in a deceased individual, there's no possible way to calculate a dose. It's not possible because of that potential change that occurs during the postmortem interval. So we have approximately 800 nanograms per milliliter of citalopram in Ms. Ward. I can't tell you how many milligrams she ingested that day or the day before or the week before. It's not possible.
My hypothetical involves somebody with 840 nanograms alive. Is there any way for a forensic toxicologist to state how many 20 milligram pills it would take to get somebody to 840 nanograms per milliliter while they're alive?
Alive, yes, if you have sufficient information. For example, it gets very complicated, so I don't want to go into all the details, but you need to know the volume of distribution of the drug, the half-life of the drug. I know it gets too complicated. In a living person, you can do that with the information that's given. In a decedent, it's not possible.
Can you give an opinion for a living person, hypothetically? Would it involve more than taking 60 milligrams for the second time in one day?
In a living person with an 843, probably took more than 60 milligrams. Unless there's an issue, let's say, with their ability to metabolize a drug, which means break down the drug, or maybe their ability to eliminate the drug. That would be like through the kidney. So people who have renal function issues, people who are on dialysis, their medications have to be done very, very carefully because they're not excreting drug the same as like you and I. But yes.
Okay. All right, have all of your opinions been given within a reasonable degree of toxicological certainty?
Yes, sir, they have.
No other questions?
Cross.
Good morning, doctor.
Good morning.
We've met.
Yes, we did this morning.
I want to talk about the things we agree about.
Sure.
We agree that Mrs. Ward was taking Celexa for a long period of time.
Yes.
5 years?
I think it's 50 months. That's not 5 years. I don't have her medical records.
Let's say 50 months. Have you looked at her medical records?
I have not.
Okay. But you're aware that she had been taking Celexa, citalopram for 50 months.
Yes.
And you're aware that she was prescribed the Celexa, citalopram for depression.
Yes.
And we agree that the dose Mrs. Ward was taking was on the high level of dose.
Yes.
And we agree that Mrs. Ward had citalopram in her system when she died.
Yes.
We agree that Mrs. Ward's blood alcohol level when she died was over the legal limit.
Yes.
And we agree that you don't know what the effect that alcohol had on Mrs. Ward that night.
I have no idea.
We agree?
Yes.
We agree that you don't know what effect the citalopram had on Mrs. Ward that night.
Not necessarily.
Okay, you know what effect that Celexa and that citalopram had on Mrs. Ward on September 21st, 2009.
I don't think we have evidence that she was overdosing or succumbing to the toxic effects of the citalopram on that day.
Doctor, has anyone ever suggested that Mrs. Ward overdosed?
No.
Okay, so my question to you is, you don't know what effect the citalopram that you've acknowledged was in her system, you don't know what effect that had on Mrs. Ward on September 21st, 2009.
I don't know the effect, but I don't have any evidence per se that would suggest that she was having issues with the drug.
One way or another.
That's right.
So you don't know,
Yes.
correct?
Yes.
Is alcohol a central nervous system depressant?
Yes.
Does alcohol reduce inhibitions?
Yes.
Is one of the noted side effects of Celexa citalopram in excessive doses aggression,
Potentially.
hallucination,
Maybe.
possibly?
Possibly. Yes.
And patients are told not to drink while taking citalopram, correct?
They're cautioned about it.
Doctor, thank you. That's all I have.
Redirect. Mr. Ellsworth, this witness be excused.
Yes, Your Honor.
All right, thank you, doctor. Free to go.
Thank you.
I got him, I think, right?
Call your next witness.
Beata Vida, B-E-A-T-A.
You may inquire.
Thank you. Good morning, ma'am. Can you please tell us your name and spell your first and last name?
Good morning. My name is Beata Vida, and it's spelled B-E-A-T-A-V-I-D-A.
And where do you work?
I'm currently employed by the Las Vegas Metropolitan Police Department as a forensic scientist in the biology DNA section.
And prior to working for the Las Vegas Police Department, where did you work?
I worked for the Florida Department of Law Enforcement in Orlando as a crime laboratory analyst.
And in which section?
Biology.
And does that involve doing...
Can you move the microphone a little bit?
Sure.
Just to see? All right, try it now.
All right, you mentioned you work at the Orlando office of the Florida Department of Law Enforcement. In what division?
DNA biology.
And tell us about your educational background.
I have a Bachelor's of Arts in Biology with a minor in Chemistry from Minnesota State University, Moorhead. And later on, I also received my Associates of Science degree in Crime Scene Technology.
And was your first job in this field at the FDLE?
Yes.
Is there any sort of additional training they give you, or do you start in casework with your bachelor's degree and your degrees?
Absolutely. When I started at FDLE in December of 2005, I went through a documented and formal training program that lasted a little over a year. During that time, I did a lot of reading on DNA, serology, and worked on a lot of samples that we commonly encounter in the laboratory. In addition to that, I took a number of written and oral exams, and then I was required to work with another experienced analyst for 6 months after that under supervised casework, and then I also had to pass a competency test before I was allowed to do casework on my own.
And would they ever give you some proficiency tests along the way so that you could maintain your status as a caseworker?
Yes.
And tell us about that. How would you get these tests?
A proficiency test is basically a test that is sent to me from an outside agency, and it's a mock case with mock samples, and I would work it just like I would a regular case. Once the case was finished, I would write it up and send my answers back or the results back to this agency, and there they would check it to make sure that I got the results that I was supposed to. And I did that twice a year. I still do that twice a year.
And the Florida Department of Law Enforcement lab itself, does it enjoy any accreditation?
Yes.
And from whom?
ASCLD Lab, which is the American Society of Crime Laboratory Directors Lab Accreditation Board.
And do you have to meet, what sorts of standards do you have to meet to get an accreditation from that society?
They have been accredited since 1990, And basically, accreditation is a voluntary program that any laboratory may join to show that their personnel, operations, management meet specific standards.
All right, and in addition to doing testing for DNA, do you also do any serological testing for things like blood, semen, saliva?
Yes.
And what steps would you take first in the process? Would you do that serological testing to search for potential sources of DNA first?
Yes.
All right. Now, when you do some casework in the Florida Department of Law Enforcement lab, how is it that you get any particular item in your hands to do the work?
So all the cases that I had were randomly assigned to me by my supervisor, and I would request the evidence, and then the evidence would come to me from downstairs, and I can go into how the evidence came into the laboratory if you'd like.
Is this lab a secure facility, or can I just come in and pick up some DNA and take it home and bring it back?
No, it's very secure.
All right, now when you're doing this sort of work, what are you wearing? Not like your suit, I'm talking about like protective clothing for both yourself and the evidence.
Yeah, so we try to not only protect ourselves from blood and other blood fluids we look at, but we also try to protect the evidence. So whenever an evidence is being worked on, I always wear a lab coat, a hairnet in some cases if there was hairs involved, gloves, and each individual case is worked by itself. Each individual evidence is worked by itself. And when we're working question samples, we would work it different from known samples.
Do you sterilize your work areas?
Absolutely.
Do you have vented shafts so that the air goes up and out of the building instead of all over your lab?
Yes.
Do you wear anything when you're doing DNA work to cover your mouth and nose?
Yes, we also wear masks.
All right. So let's talk about DNA. You ever heard of that?
Yes.
What is DNA?
DNA stands for deoxyribonucleic acid, and it's the blueprint or set of instructions that codes for everything in the body. It's found in cells, and its purpose is to pass down genetic information from one generation to the next. And everybody has their own unique DNA, except identical twins, and you also get half of your DNA from your mom and half of it from your dad. And it's also consistent throughout your lifetime, so it never changes.
And are most cells in our body, do they contain this DNA, this nuclear DNA that we're talking about?
Yes.
Are there some cells that don't?
Yes.
And what would those be?
Red blood cells in the blood.
How about skin? First of all, would you agree that there's many layers to one's skin?
Yes.
All right. Tell us about skin and how one may or may not get nuclear DNA from skin.
So skin cells are basically cells that cover either the outside of the body or also inside the body, organs and things like that. And the skin cells contain cells that contain the DNA. And the way we refer to touch DNA, or this type of DNA, is touch DNA, because it's through skin, and we can get it from things that people have touched or have come into contact with.
Now, every time I touch something, do I leave DNA on it?
Not necessarily.
And are some people more likely to shed their DNA than others?
Yes.
Are some surfaces better than others for leaving this touch DNA?
Yes.
Is the force of friction something that is useful for leaving touch DNA, if there's friction applied between the skin and whatever's being touched?
Yes.
Can touch DNA or any DNA be transferred from one place to another by a person or a thing?
It can be, yes.
Can DNA be projected, such as if you're not wearing your face mask and you cough or sneeze?
Yes, it can.
Okay. Now, how is it that you test something potentially for DNA? So let me take an example. Were you provided a DNA card that was represented as having come from Mrs. Diane Ward?
Yes.
May I approach?
You may.
I am showing you what has come into evidence as States 36. Can you tell me whether or not you're familiar with States 36?
Yes, I am.
And how are you familiar with it?
It has my initials, and also there's some markings that I made that are under here.
And so is it fair to say, and correct me if I'm wrong, when you receive that envelope, Is it sealed with evidence tape from a law enforcement agency?
Yes, if it's not sealed, it's returned to the agency, and if it accidentally gets through, when I get it, if it's unsealed, I'm not going to work it.
And when you're done with it, do you put your own special evidence tape on it with your initials?
Yes,
And do you write on the envelope, as you were saying, FDLE case number as opposed to the law enforcement agency's case number?
yes.
And do you all have some sort of system, either you, and by you all I mean you or law enforcement, for numbering things with K something and Q something?
Yes.
Can you explain, for example, on 36, I believe that's K4. What does the K mean in K4?
The K means that it's from a known sample, and so anything that had a name attached to it where we know that it came from a specific person, it would be a K, and then everything from crime scenes or any evidence would be labeled as Q for question.
All right. Now, from prior testimony, our understanding is there's a DNA card which might have a few drops of hopefully blood on it. Is that what you remember examining?
Yes, so for known standards, we can either get something like from blood standard, or we can get buccal swabs, which are swabs from the inside cheek of a person, and that would also be considered a reference standard.
Now, do you do any confirmatory testing as to whether or not this is blood before going to DNA analysis, or do you take their word in this instance that it's blood?
Not in this case. We only test for those things on evidence.
All right. So the answer is no, you didn't do any chemical testing to see if this was really blood.
Correct.
Well, take us through, how do you take a card with some blood drops on it and turn it into a DNA profile?
So what would happen is I would open the packaging, and most known samples are worked at the end. So first we look at question samples, and then known samples I looked at the end. So in this case, I opened the envelope, I made my markings, I took notes of what I saw, and then a cutting is taken of the staining. Then that stain is put into a tube, and then we go through 4 different steps to get the DNA from the card.
Step 1.
Step 1 is, as I mentioned before, DNA is found in cells, so the first step is to get the DNA out of the cells. And we do that by adding heat and chemicals to the sample to release the DNA. Then the next step is finding out how much DNA is present on a sample. Some samples have a lot of DNA, for example, known samples, and some samples have less DNA. For example, touch samples occasionally have less DNA. So we need to know what kind of sample we're working with. The third step then is to make millions of copies of the DNA that we have. We focus in on certain areas and make copies of that area so we can look at really tiny amounts and actually get good DNA profiles from that.
Can I stop you there for 1 second?
Yes.
Is that also known as amplification?
Yes.
All right. And so without going into the magic, if you know the magic, there's chemicals that will focus in on certain parts of our chromosomes and make copies of them?
Yes.
Okay. And is there anything special or unique about these parts of our chromosomes that you're trying to copy? And I'll tie that into a compound question of what is STR?
So the type of testing we do at my current laboratory and that we did at FDLE is called SCR DNA testing, STR, and it stands for short tandem repeats. And as the name implies, they are short segments of DNA that are next to each other on the DNA molecule. And everybody has these repeating units, but the number of times they repeat varies from one individual to another. So at the same location, I might have a repeating unit of 6, and somebody else might have a 7. So there's different segments. There are short and larger segments.
Can I stop you there?
Yes.
All right. And so what's a base pair? We'll get through this quick. When we're talking about DNA, what's a base pair?
A base pair is part of what makes up a DNA molecule.
All right. And without going into the names, are there base pairs of amino acids with A and G and C and T? Does that
Yes.
sound right?
That's correct.
So for example, a pattern might be AGA, AGA, AGA. Is that fair?
Yes.
All right. And just to quickly get through this, because there is, I believe in this case, a decimal point involved. Can these repeating patterns be long enough, say like if they're 10, the pattern's AG, 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 can you have a decimal point like 31.2 of that short tandem repeat?
Yes, so what happens is actually the short tandem repeats are normally made up of 4 of these units. So it would be A, C, G, T, for example, And when there is a decimal point, that means that there's not 4, but it's actually 3.
Okay. Enough of that crazy stuff. Now, after the amplification process, what's step 4?
Step 4 is to separate out the DNA by size. So we put the sample through an instrument, and the samples are separated, and then we use a software to help us visualize the DNA as peaks on a graph.
And is there something about electricity and a gel thing? Can you tell us about that?
Yes, so the instrument basically consists of a tube that is in 2 buffers, one's positive and one negative, and the DNA is injected into this instrument because DNA has a negative charge, so it goes through the instrument when a voltage is applied.
Okay. Now, when you did that with that DNA card there, were you able to develop a DNA profile for what was states 36 in evidence?
Yes.
And the instrument that you use, how does it print out or represent values to human beings so that we can look at them?
It looks like peaks in a graph, and then that's what I make my interpretations on. And then for the file, we also put a table together just to summarize what we saw on the graph.
All right, permission to work with what will be marked as states AY with the witness.
Granted.
Are you familiar with how to clear the screen?
No.
I'm going to familiarize you. Arrow pulls up the menu. Then you can do a bunch of things, but we'll clear it for now. Try to. All right, are you familiar with what you are looking at on your screen, which is one of 4 files on AY for identification, this file labeled peaks k4.pdf?
Yes, so this would be the end result of the last step, basically, of the instrument that we just talked about. And these are the graphs, what we call electropherograms or EMs, and these are the peaks on the graph that I look at and make my determinations on.
Permission at this point to use AY as a demonstrative aid?
Any objection? No objection. Granted. It's not up yet. All right, it's up now. Go ahead.
All right, so let's talk about some things. Under the Applied Biosystems Gene Mapper ID version 3.2, is that like a file name there that ends in FSA?
Yes.
All right, and what does the K4 mean as far as this part of the file name?
That was the name of the sample.
All right, now let's talk about over on the right side, there's something that says Profiler Plus version 1, I assume. What is Profiler?
It's the kit that we used to amplify the DNA back then.
And was that a commercially available kit?
Yes.
Was it widely used within the DNA community?
Yes.
And down below, I believe we're going to get into Cofiler. Tell us what Cofiler was.
It's the same thing. We just had to, back then, now things are different, but we had to amplify the sample twice in 2 different kits to get different locations.
All right. Now let's talk about in the first shaded area coming from the top left, there's a shaded area D3S1358. What does that mean?
So in DNA analysis, we're actually looking at 13 specific areas on the DNA molecule. So this was one of the areas that we looked at.
All right. And what does the little peaks below that mean? Taking first 16 and then 18. What do those numbers mean?
Those are the repeating units that I described earlier, and there's 2 peaks under D3 because half of your DNA comes from mom, half of it from your dad. So that's why there is 2 peaks. The 16 might have come from mom or dad, and the 18 from mom or dad.
All right. Now let's talk about the vertical part of this chart that goes 0, 500, 1,000, 1,500. What unit are we talking about there?
Those are called RFUs, or relative fluorescent units, and it's basically just a measure of how much DNA is on a sample.
Now, is there a certain peak height that one peak must reach before you can call it as included into this DNA profile?
Yes,
And what height would that be?
it was 100 RFU then.
And how about what heights can you start to say that somebody's excluded from a profile?
At 50 and above.
Okay. So let's talk about the numbers underneath 16 and 18. Those numbers are 1,413 and 1,228 respectively. What do those numbers represent?
That was the actual RFU, or the units on the side, but it's more specific because it's hard to tell from the side what numbers those were.
Okay. Now, real briefly, what does the horizontal chart mean? 100, 150, 200, so on.
That was the lengths of the DNA, so it basically just tells us where, it helps us identify where these peaks fall in. It's like a ruler for measuring.
Okay. Are you familiar with the term artifact?
Yes.
Can you tell us what that means and how it might relate to the little molehills?
Yeah, so artifacts are any peaks that are not actually from DNA. It can be from the PCR process or from the instrumentation, and we get trained on how to read these because there are peaks that might look like peaks but are not actually peaks, DNA peaks.
Now, in just looking at this first part of this first page, there seems to be a phenomenon where right before each peak, there seems to be a little artifact. Is that normal?
Yes.
And why is it normal?
That's what we call stutter, and it's basically a process of amplification. There's little blips that happen, but it's so low, we can see it's there, but it's not labeled. It's something we take into account, and we just ignore it.
All right, now, so to speed this along a little bit, ultimately, between the two different kits that you used back then, were 13 locations plus something called a sex marker, which we'll talk about, tested?
Yes.
And between those two kits, was there actually a couple or a small handful of locations that get tested by each kit?
Yes, so I believe it was D3 and D7 were repeated in both kits.
Okay. What's the sex marker?
The sex marker is what we call amylogenin, and it basically tells me the gender of an individual. So from a DNA profile, I can tell whether that DNA profile came from a male or a female.
All right, now these first three here, D3, VWA, and FGA, Mrs. Ward had one number from mom, one number from dad.
Yes.
Scrolling down a little bit on page 1 of this PDF, the middle one here at the top, D21S11, where the 28 is at 2,706. Is that one of those locations where mom and dad might have been the same?
That's a location where, yes, mom and dad were the same.
Okay. Now, at the beginning, on the far left of this top chart in this image as it's displayed, there's an X, and it's 2748. Is that the sex marker?
Yes, an XX, or in this case the X, represents a female, and an XY represents a male.
And do you recall which date you developed this profile? I don't know if it's on there.
I do not.
All right. However, do you specifically remember that you did not have Mr. Ward's sample yet at the time that you ran this sample?
Yes.
And we're going to start talking about some unknowns. Did you run those unknowns at a time before you had Mr. Ward's sample in the lab?
Yes.
Ultimately, did you develop a DNA profile at all 13 locations and the marker for gender on this 36?
I did.
Was it suitable for comparison to unknowns?
Yes.
Sorry, numbers versus letters. All right, may I approach the witness? Showing you E for identification states 16 in evidence. Can you tell me whether or not you recognize that?
I do.
And how do you recognize it?
It has the date that I examined it, our FDLE event number, and the item number,
And what do you recognize it as being?
K5.
And that doesn't seem to be as flat as the DNA card. What was in that?
These were buccal swabs represented as being from James Robert Ward.
And again, you received it in a sealed envelope, or else you would have sent it back on home,
Yes,
and then you sealed it when you were done?
yes.
Did you take, well, is there any difference in how you take a cutting from a part of the buccal swab as opposed to the DNA card to start this process?
So yes, a buccal swab looks like a Q-tip, and so we just take a tip of that sample and then place that in a tube.
Then otherwise, steps 1, 2, 3, and 4 are the same.
Yes,
And were you able to develop a DNA profile from this standard?
I was.
And in your K and Q system, and maybe it's not yours, maybe it's law enforcement's, was this K5?
Yes,
Permission to use, at this point, demonstratively, the file DNA peaks K5.pdf on AY?
Permission granted. It's not up yet. Now it's up.
Okay. Real briefly, same question. Like, for example, with D3S1358, he had 15 and 18. So again, that's mom and dad are different.
correct.
And the numbers below are the RFU height.
Yes.
Okay. Then in the second row on this first page, as one would expect, there's an X and a Y, correct?
Yes,
For a male?
yes,
And their peak heights are 1002 and 1006?
yes.
All right. Now, just briefly, we'll get into it more in a little bit, but is there anything as far as percentage-wise that you have to look at from one peak in relationship to another peak before you can say it belongs to the same person potentially?
Yes. Normally, a person's DNA profile, when it comes out in an electropharogram, all the peaks will be equal height. And in some cases, we do get mixtures where it's a DNA profile from multiple individuals, and depending on how much DNA each individual contributes, there might be differences in the heights of the peaks.
All right, well, let's talk about even just with this known one, D21S11. 29 shows RFUs 754, and then that decimal point we were talking about, 31.2, shows 989. Again, they're different, and it's a known sample. Explain that?
It's not different enough. The peak heights difference has to be more than 60%. So if it's above 60%, it's fine. So in this case, it was still a single source profile, and there was no indication of a mixture.
And the percentile is generated by dividing one number into the other?
Yes, the small number into the large,
Okay.
multiplying it times 100.
So 29 divided by 31.2, or is it vice versa? Is it 29 divided by 31.2 or opposite?
No, it's the RFU actually divided.
Yes, you're right, silly me. So it's 754 divided into the bigger number, 989.
Yes,
And if that ratio is over 60 or 0.6, 60%, you're not concerned that there might be a second person involved.
correct.
Fair enough. May I approach the witness?
You may.
And again, Mr. Ward's DNA profile was developed on a later date than Mrs. Ward's and the unknowns?
Yes, I believe it was a month later.
Okay. First, let's go with K for identification. States 29. Can you tell me whether or not you're familiar with that?
Yes, it has my markings on the envelope again.
And again, was this a card or was it the boxes that contain swabbings?
These were also swabbings.
And what do you recognize it as?
Q2. And it states it was 2 swabs of blood from right shoe.
All right. And so did you take this process the same as you did, as we've described for the other swabbing?
Yes, But I also, since there was some discoloration on the swab, I did actually do a test to see if it might be blood present on the swab.
Ah, yes, let's back up to that. So since this was an unknown, did you do that chemical serological testing before stepping into the DNA world?
Yes.
And what were you looking to test it to see if it was?
I was checking to see if it could be possibly blood, the red-brown stain that I observed on the swabs.
And how do you test something to see whether or not it's blood?
So it depends. If there's a lot of discoloration, if there is a lot of red-brown staining on the swab, I will normally take a filter paper and rub the swab on it and then test the filter paper with 3 different chemicals. And if there is a really bright pink color change, that tells me that there is an indication of blood. In some cases where there is only a faint discoloration, I take a cutting of the swab and then a tiny cutting and then test that instead.
So did this give any chemical indications of being blood when you did that?
Yes.
So did you step to DNA testing?
Yes, I took a cutting of the stain and then took that onto DNA.
And then steps 1, 2, 3, 4.
Yes.
Were you able to develop a DNA profile from that?
Yes.
And at all 13 locations and the amylogenin?
May I look at my report?
Actually, we can do better. Did you summarize? Well, actually, no, not for Q3. Can you look at your report?
Yes. Yes, so for Q2, I obtained a mixed DNA profile that
Okay.
demonstrated presence of at least 2 individuals.
All right, so it's Q2, just so the record's clear. I might have said 3 earlier. All right, and so how does one determine whether or not there's a mixture? Why would you suspect there's a mixture?
Again, as I said before, normally for single source profiles, we will just see 2 peaks, one from mom, one from dad. For mixtures, we will see more than 2 peaks at the locations. So it could be 3, 4, 5, 6, depending on how many people are in the mixture.
Now, can you tell us what the term major profile means versus minor profile versus inconclusive?
Yes, so in some cases, when we have a mixture, we're able to separate the DNA profile out, so untangle it, so we know which DNA profile belongs to which person. And in some cases, when everybody contributes equally to the mixture, we're unable to do that. So in some cases, we might be able to say that there's a mixture of people and provide statistics, and in some cases, it's just too complex and we can't.
And so with these particular peaks on Q2, were you able to say whether there was a major profile versus a minor or an inconclusive profile?
I was able to tell that there was a major and a minor DNA profile.
And did you do any comparison of this major profile on Q2 to the knowns of K4 and K5?
At this point, when I worked Q2, the only comparison I could make was to K4, which was Diane Ward.
And was there any comparison to be made?
Yes,
And did it match,
it did.
for lack of a better scientific term? Is it called a match?
Yes.
All right. Now, in order for these matches to have any significance in the world, do you use statistics?
Yes.
And back at 2009, what was the statistical model the FDLE used, and what was your familiarity with it?
We used the FBI's DNA database to make our calculations. So every time there was a match between an unknown and a known DNA profile, we provide statistics to show how common or rare that DNA profile is in the population.
And is that done with some sample studies of, I believe the groups back then, were they Caucasian, African American, Southeast Hispanic?
Yes, there was a lot more groups that were actually studied, but those are the ones that we use here because that's what most of the population here is made up of.
And are we talking like in the terms of hundreds or thousands or tens of thousands of people in these studies?
There's usually between 100 to 150. For the FBI, they use approximately 200 people of African Americans, Caucasians, and Southeastern Hispanics.
And how can that translate into giving us meaningful comparisons when there's like 7 billion people on Earth?
So studies have been done to show that 150 to 200 people are all plenty to actually estimate, make estimations, and also each of those people would have two two alleles, so therefore we're actually looking at 400 of these data.
Okay. Now, does what your numbers are at location A, does that have independent significance from B, C, D, so on and so forth to whatever the 13th is, I guess M?
Yes, they are not linked. So whatever kind of DNA profile you have at your first location doesn't influence what you have at your second, third, or fourth.
So if the chances are like 1 in 10 at one location, can you start to explain the product rule?
Yes. So the product rule is a mathematical formula that allows us to multiply independently occurring events together. So simply put, if you, for example, want to know how many times you can flip a coin and get heads 3 times, if you have a 1 in 2 chance of flipping heads when you flip the coin first, then again, it doesn't change. It's still going to be 1 in 2 the second time, and then 1 in 2 the third time. So that's actually the product rule, and you end up with 1 in 8 chances of flipping heads. So that's exactly what we do. We take each of the locations and multiply them together to get the complete or the total frequency of all of the 13 locations.
And so,
Hold on. Just hold on 1 second. Sorry. Go ahead. Thanks.
so in applying this statistical model to the relationship between the major profile on Q2 and the known profile of K4, what was the statistical significance attributed to this relationship?
So the frequency occurrence for the major DNA profile obtained from Q2 for unrelated individuals in the population was 1 in 400 quadrillion Caucasians, 1 in 9.5 quintillion African Americans, and 1 in 1 quintillion Southeastern Hispanics.
And I believe I mentioned it, but do you agree 7 billion people on this floating rock?
It's 7.5 now, yes.
Okay. So this is many, many, many times the Earth's population?
Yes, a quadrillion is actually a number followed by 15 zeros.
Can you say this was Diane Ward's blood on K2?
FDLE did not make those statements. All we did say was it was consistent.
Okay. And once you got K5 run through, was there any relationship between the minor profile and K5?
The DNA profile for the minor contributor could not be determined.
Okay. And what does that mean? How do you reach that conclusion?
That means that I could tell there was a minor profile. There were some peaks on the electrophotogram, but they weren't good enough for us to actually say if a person was included, excluded, so no determinations were made about it.
Does that relate back to what we said earlier about 50 being the cutoff to start excluding people and 100 to start including?
Yes, we want to have good data before we make those determinations.
Okay. All right. So you also have another exhibit up there. What's its number?
Q3.
And the yellow rectangular tag. There you go.
Exhibit 31, identification L.
All right. And are you familiar with that item?
Yes.
And what was it represented as being as far as the label?
2 swabs of suspected blood from pants.
And were they in those boxes for swabbings?
Yes.
And did you do the same thing you did with the other swabbings from that we've talked about?
Yes, I visually examined them. I did see some red-brown staining. They were fainter this time, so I took a little cutting of the swab and tested that for the possible presence of blood.
And did it give the indications chemically of being blood?
Yes.
Bright pink.
Yes.
All right. So therefore, you proceeded to DNA testing?
Yes.
Were you able to develop a DNA profile with your profiler and co-filer kits
Yes.
at all locations?
Yes.
And did you compare that to K4?
Yes, I did.
And what did you find?
A complete DNA profile was obtained from Q3, and the DNA profile matched the DNA profile from Diane Ward.
Same statistical significance as we just discussed with the previous exhibit?
Yes.
Any minor profiles or inconclusive things going on in this one?
No, this one was just a single source DNA profile.
Okay. May I approach again, Judge?
You may.
Showing you 32 and 35. Can you talk about 32 first? Do you recognize it?
I do.
What do you recognize it as?
It was item Q4, and it was 2 swabs collected from the cylinder of a 357.
And again, was it in a box with a large Q-tip in it?
Yes.
And did you do any preliminary chemical testing for blood, saliva, semen, or anything like that?
Yeah. So when I took a look at that, I didn't see any discoloration of any staining that would tell me that it was possibly body fluid, so it was not tested for anything.
Did it proceed to DNA testing then?
Yes.
And were you able to develop a profile?
Actually, I don't believe I examined this item because this is cylinder, and I didn't look at a cylinder.
Okay. And why not?
I don't think it was requested.
Okay. How about the other exhibit up there?
Yes.
And for the record, what number?
This one is Exhibit 35.
All right. And are you familiar with that item?
Yes, it was Q6.
And what was it labeled as said to have come from?
2 swabs collected from barrel of 357.
All right. Did you visually inspect? Well, let's back up. Was it in a box with a Q-tip?
Yes.
Did you visually inspect it?
Yes.
And upon visual inspection, did you proceed to chemical testing or DNA testing?
If I would have seen anything, I would have done the chemical testing, but I didn't see anything, so it went right through DNA.
Were you able to develop a DNA profile?
No.
All right. Not a single loci or location?
No. There
Okay.
was no DNA results obtained.
May I approach again, Judge?
You may.
Showing you 33 and 34. Tell me if you recognize both of those items.
I do.
And what do you recognize 34 as?
34 is Q5, and it's 2 swabs collected from the trigger of 357.
And what was the other exhibit, 35?
The other one, actually, it's Exhibit 33.
Yes.
It's Q4, and it's 2 swabs from grips of Smith & Wesson 357.
All right, now let's talk about these exhibits. Were they also boxes with the long Q-tips in them?
Yes, with 2 swabs.
Did you visually inspect them for blood?
I did.
Did you see any indication of possible blood?
I did not.
So did you do any chemical testing on them?
No.
Did you then proceed to DNA testing?
Yes.
Now, did you test these 2 items separately, or did you test them somehow together?
I tested them together.
Describe how you did that, and then we'll go into why.
So what I did was I opened one item of evidence, 2 cuttings, and then I sealed that evidence back up, and then I opened the other item of evidence, 2 cuttings from that, and put the cuttings into the same tube and combined them, and then ran them together as one sample.
And why did you run these 2 samples together?
Because in the actual request, the requester wanted to know who handled the firearm, and so in order to get the best DNA profile possible, I combined the 2 samples together because it was the trigger and the grip. So it's very hard to get a DNA profile from a very small surface, such as a trigger, for example, and to get the best possible DNA again, I combined them. And furthermore, it's also very hard to handle a gun with just holding the trigger or the grip.
And so is this the first and only time you've ever done this?
No.
Is that something you routinely did?
Yes, it was a common practice to try to get the best DNA profile. I mean, if it was 2 separate items, for example, a glove and a cup, we would never do that. But because these swabs came from the same item, we were allowed to do that.
And when you say common practice, is it common practice for just you, or is it common practice and accepted within the forensic community of DNA testing?
It was accepted back then. Now, actually, what we would do today is actually swab the entire item with one swab.
And so when you say swab the entire item with one swab, does that include the barrel?
In this case, no, because the barrel, I was looking for something else. The requester was looking for blowback, so it wasn't.
I'm backing up to this hypothetical. You said nowadays you would just swab the gun once, and I was wondering, does that include the barrel or just the external?
It would depend on what I'm looking for, what the requester is asking for.
All right. And so if you were looking for the handler, what would you do now if you had samples from the cylinder, the grip, the trigger, and anywhere else on the gun?
I would combine all of them.
All right. And is that your practice, or is that a common practice within the field of forensic DNA testing?
It's common practice unless the requester specifically says that they want something tested separately, then of course I'll test it separately because I'm not at the crime scene, so I don't know the story of what happened.
All right. So now let's talk about what we will call, for lack of a better term, Q4, Q5, this new exhibit, right?
Yes.
Were you able to develop a DNA profile from it?
Yes.
All right, now let's talk a little bit, let's back up a little bit more. Is there a part of this process in stages 1, 2, 3, or 4 called injection, or have an injection in it?
Yes.
Which step is that?
That's the last part. Before we get to the separation of the DNA, we actually have to get the sample into the instrument, and we do that by applying voltage to inject or migrate the DNA into the instrument.
And so normally, how long do you do that?
10 seconds.
And is that standard common practice for DNA testing?
Yes.
All right, so you did that at 10 seconds?
Yes.
Now let's talk about what you found after 10 seconds. In preparing your reports, can you still see the screen?
Yes.
All right.
Hold on. Oh, you're not publishing to the jury.
I'm not publishing to the jury yet.
Okay, go ahead.
And for the record, we have switched from AY to something that I'll have the clerk mark as AP when I get a
A
chance.
what?
It's going to be AP,
P? Okay.
as in Pete and repeat. What are we looking at here on this first page, or the top of the first and only page?
This is the summary of my electropherogram.
And for whom, or which sample?
For K5,
All right, and does that have the run date on it when you did it?
yes.
And does that summarize the results for that sample?
Yes.
Below that, is that a results sample summary for Q4, Q5 at 10 seconds, Q4, Q5 at 22 seconds, and then a summary of the major profile from Q4, Q5 at 22 seconds, and then minor alleles at Q4, Q5 at 22 seconds, as well as K4 ward, which we know as Diane ward.
Yes,
And did you prepare this data and it was in your reports?
I did.
And would it be helpful for you to have this shown to the jury to help explain and demonstrate your testimony?
Yes.
Okay. Permission to publish AP to the jury for demonstrative purposes?
Any objection? All right, granted. It's not up yet.
Did I bring that up to you yet?
It's up now.
That's A. All right. So yes, it is AP, and Madam Clerk is marking it as such. All right, so as we were looking at with the peak charts, there was a D3S1358, correct?
Yes.
And in your chart, you listed as 1518 for Mr. Ward,
Correct.
and then so on and so forth for 13 total locations, plus the amylogenin is XY. Is that fair?
Yes.
Okay. Now let's talk about this first I guess it's column, for Q4-5 gun swabs. It doesn't say 10 seconds there, but was that done at 10 seconds?
Yes,
And does it not say 10 seconds there because 10 seconds was standard?
correct.
All right. And does it have the run dates for when you ran that?
Yeah, so those are the dates where it actually went on the instrument and the sample was run.
So October 13th, 2009 is when you did the 10-second Q4-5 and Mrs. Ward.
Yes,
And then the following day, you did the 22-second, and we'll get to that.
yes.
All right. Now, looking at D3S1358, it says 15 * 18. What does that mean?
The stars are basically placeholders. So as I explained before, we had thresholds or points where the peaks had to be above for us to actually call a number. So the 15, 18 was above that threshold, and then the asterisks were not. So I did see a peak there, but it was between 50 and 100. So our practice was to actually just put stars there as a placeholder.
All right, and so to quickly summarize the results of Q4, Q5 at the standard 10-second injection, did you develop a major profile in comparison to K4 and K5?
I did see a major profile at that point, but I decided to inject the sample for a longer period of time to try to get better data.
Okay. Did that major profile at that point match either K4 or K5?
Yes.
And which one? I know it's unfair because,
It matched K5.
okay. At all 13 locations?
No, just at the locations where I was actually able to pull out a major DNA profile.
Okay. And even at 22 seconds, it appears that at one location, D18S51, it was inconclusive.
Yes.
So I assume at 10 seconds, it was probably inconclusive as well.
Yes.
All right. But you could still, if you had wanted to, instead of proceeding to 22 seconds, you could have ran statistical significance for 12 locations.
Possibly, yes.
Okay. Now, why did you decide to do 22 seconds in this particular case?
Because I could tell that there was data there, so I wanted to see if I could get even better data by injecting the sample for a longer period of time.
All right, now let's talk about that. So you did that. Let's talk about the first location, D3S1358 again. Now it says 15, 16, 17, and 18. As you mentioned earlier, since there's more than two, did you suspect that there was more than one person involved?
Yes.
Now, you also mentioned earlier that if the peak heights are too close, it might be hard to really say who's who, correct?
Yes.
So were you able to look at these relative peak heights and determine one was major and one was minor?
Yes.
And at that location, was the major 15, 18, as your charts say?
Yes.
And again, that correlates to K5, Mr. Ward?
Yes.
In the 16, 17, how did that relate to Mrs. Ward?
So I wasn't able to actually pull out a minor profile from this mixture. I could tell it was at least 2 or more individuals. So instead of saying it was a minor profile, we just say minor alleles. So whatever numbers don't belong to the major, we have a column and just list those out.
Okay. And so Mr. Ward nor Mrs. Ward is a 17. What, if anything, does that tell you?
That there were probably more than 2 people in that mixture, possibly.
Okay. And how long can DNA stay on an item?
Under the right circumstances, it can be years. Environmental factors such as heat, sunlight, humidity will break down DNA, but if something is inside in a cool, dry place, it can be for years.
All right, so at that location, you're able to attribute the major profile to Mr. Ward, K5, but what's the relationship you would say Mrs. Ward had to that location?
So she didn't match the major. She was excluded from that, but then no determinations could be made regarding her contribution to the minor.
All right. Second location, VWA, at 20 seconds or 22 seconds, it's 15, 17, 18, and 20. Major profile is 15, 20. Does that belong to K5, Mr. Ward?
Yes.
And the minor alleles is 17, 18, and apparently Mrs. Ward was. Were you able to say that it was Mrs. Ward, or was this inconclusive?
No, the no determination means that it applied to the entire minor DNA profile.
Okay. So for every location, even if the numbers are there, as far as being similar to Mrs. Ward's, it's inconclusive to call her the minor profile?
Yes, because first we look at the evidence, make our determinations, and only after that do we make the comparisons to the standards. So I already made my determinations up front saying the minor contributor is going to be inconclusive. So whether after that it was no determinations no matter what kind of alleles I saw. What kind of markers I saw.
All right. And so if we were just to summarize, even though you're not able to say that she was the minor profile, there's only a handful of locations where the number is even similar to Mrs. Ward's profile. Is that fair to say?
Yes.
And there's several locations where there's a hyphen. What does that mean in the minor alleles?
That means that there weren't any additional alleles other than what I saw in the major.
And what about when there's just an asterisk?
That means there were peaks there again, but again, it was in that gray zone where we don't really make any determinations on.
And what about at location D16S539? It appears that Mr. and Mrs. Ward just happened to be one of those people, or two of those people, that had the same one, 1111, 1111. There's a 12 there.
Yes.
What can you tell us about that?
That I can tell you that it's an allele that doesn't belong to either.
And then there's the inconclusive one, even for the major profile.
Yes.
Does that mean that Mr. Ward is excluded as the major profile donor because there's one of the 13 locations is inconclusive?
It just means that no conclusions could be made at that location.
And how is it that, you know, the numbers and the peaks can be high enough to make a call on somebody at many locations, and then at a different location it's inconclusive?
It's possible because of the different lengths. So it's possible that this location was a longer location and the DNA was broken down at that point. So the data that I got, I couldn't confidently say that that was the major profile at that location. So to be safe, I called it inconclusive.
All right, so to summarize with Q4, Q5, you cannot say that Mrs. Ward had her DNA on that gun as the minor profile.
Yes, no determinations were made regarding her contribution.
Was there any statistical significance in the relationship between Mr. Ward's profile and the major profile that was developed on this exhibit?
Yes, so after his buccal swab was submitted and I worked it, I went back to my original report and I prepared a new report, which was submission 2, and that's where that comparison took place.
And what's the statistical significance?
Because in this case, it was a partial DNA profile for the major, which means I didn't get information at all of the 13 locations. For 12 loci, the frequency of occurrence of the major DNA profile obtained in unrelated individuals were 1 in 1.3 quadrillion Caucasians, 1 in 35 quadrillion African Americans, and 1 in 1.3 quadrillion Southeastern Hispanics.
Now, returning back to AY for identification, this is something I'm just showing the witness at this point. The other two files there, one is labeled DNA 10 seconds Q4, Q5 PDF. I'm going to ask you if you recognize this data.
I produced it, yes.
What do you recognize it as?
This is Q3,
Well, it begins with Q3.
Q4, and 5.
Yes, ma'am. And does this, the 10-second?
Yes.
All right. I'm going to show you the last file on AY for identification. It's labeled DNA 22 seconds, Q4, Q5. Do you recognize this?
Yes.
And what do you recognize it as?
Q4, Q5 at 22 seconds.
Okay. Your Honor, this time the state would move AY for identification into evidence.
All right, this will be received as State's Exhibit number 43 without objection.
Permission to publish?
Granted. It's up.
Okay. On page 1 of this 4-page PDF labeled DNA 10 seconds Q4 Q5, let's start with the shaded area that says D3S1358. What can you tell us about the data underneath there as far as 15, 16 with an asterisk, 17 with an asterisk, and 18?
So I can tell that it's a mixture of 2 people because there's more than 2 peaks at that location. And as you can see, there's different height differences between the peaks. So I could tell there was going to be a major DNA profile and a minor DNA profile. And again, the asterisks mean that it's between that zone, between the 50 and the 100, where we weren't making calls.
And was the ratio between the 15 and 18 within your parameters of 60%?
I believe so, but my evaluation was actually on 22 seconds.
Okay. I'm just using this as an example, but that's what you would be comparing to see if that belonged to the same person potentially, if they're within 60% of each other?
Yes.
And now, hypothetically, if the 16 and the 17 were up there in that range between 300 and 446, then it would be difficult to say which ones belong to which person. Is that fair?
Exactly. Then it would just be called a mixture and no major or minor DNA profile.
And there's nothing preventing a DNA result as coming back with 3, 4 peak heights all in the same range of each other. Is that accurate?
That's correct.
It's not like, in law school, they have these horrible things called grading curves where only 5 people can get an A, for example, 5 people are going to get a C, and then everything else. It's not like that with DNA. There's no limit on how many peak heights can be how high?
No. Also, there's no limit of how many people can be on an item.
So you could have 5, 6, you can have some crazy mixtures.
Yes.
And in fact, you can have 5, 6, 7 peaks that are all within 60% of each other and make your job miserable.
Yes. At that point, we just call it a complex mixture and not even touch it.
All right. And then going through the rest of this exhibit, one can see the different peak heights and the number of short tandem repeats if they wanted to look through it all.
Yes.
Okay. Now let's talk about what you did actually use for your analysis at the 22 seconds. Is that what we're looking at here now in this file labeled 22 seconds, Q4, Q5 PDF?
Yes.
All right, let's talk about, just for example, D3S1358. Is your 15 and your 18 within your 60% ratio to say that belongs potentially to the same person?
Yes.
And is your 16 and 17 within ratio to each other?
Yes, but unless we call an actual minor DNA profile, we don't really care if they are or not.
Okay. And what is the threshold to call a minor DNA profile? I mean, how many different locations out of the 13 plus the sex marker? How do you explain that? Please help us understand the difference between calling a minor profile and not.
If the DNA profile is robust, in some cases, it's very easy to tell who left more DNA versus who left less. So if this was only a two-person mixture and the 16 and the 17 were, let's say, at 200 and the 15 and the 18 were a lot higher, I'm pretty confident in both of those calls. So I would be confident in saying this is the major profile and this is the minor DNA profile. So it just depends on the amount of DNA that is on the item.
And if one were so inclined, they can go through and see each location that the profiler kit tested and then the co-filer kit.
Yes.
What is these little static, what's going on here?
This is just the baseline on the instrument. Every instrument has noise, or it's the byproduct of the instrumentation, and basically that's why we have our first threshold to make sure that none of this is taken into account, and that's where the 50 actually comes from, is to go above this noise.
And so the noise, the RFUs are like, for example, only going up to 100 and then whatever would be next after 63. So that's really low. This is the noise.
Yeah, so actually that peak there doesn't look like a real DNA peak to me at all, but all the other peaks next to that, those are also artifacts.
Okay. I don't have any other questions with this witness.
All right, we're going to take a break, Mr. Ellsworth. We've been, this witness has been on the stand for 2 hours. I think even the court reporter needs a break at this point. So,
Thank you.
let me see the attorneys for 1 second. Thanks. We're going to take a 10-minute break if you guys want to move, and then we're going to come back, finish this witness, and break for lunch. All right? So if you all want to go ahead and exit.
No,
Okay. Do you remember being deposed in this case?
I knew that they wanted to
Ma'am?
know.
Do you remember being deposed in this case?
Yes,
Do you remember that was out in Las Vegas?
yes,
And do you remember you were under oath?
yes,
Do you remember being asked this question and giving this answer? Question. But in this, and counsel, it's the deposition, page 85. I'm going to read lines 17 through 20. Question. Okay, but in this case, you knew that they were interested in who pulled the trigger, right? Your answer, yes. Was that question asked? And was that your answer?
yes, but how I interpreted it was who handled the gun.
Okay. Do you remember also testifying in a prior proceeding in this courthouse?
Yes,
And also under oath? Correct?
yes, correct.
Okay. And now, counsel, I'm reading 1503, lines 9 through 11. Ms. Vida, do you remember being asked this question under oath? You knew they wanted you to determine who pulled the trigger, right? Answer, yes. And I can show it to you if you'd like.
I don't remember saying that, but if that's what it says, then I'm sure that's
May I
what it says.
approach, Judge?
She said that she accepts that's what she said.
You accept that that's what you said under oath, correct?
Yes.
Okay, and again, you said under oath that you were aware they wanted to know who pulled the trigger, correct?
Correct.
Okay. Now, there were 2 swabs collected on the trigger,
Yes,
and there were 2 swabs collected on the handle.
on the grip, yes,
Okay, we'll call it the grip. They were sent to you separately, correct?
correct,
Separate packages.
yes,
No instruction was given to you by law enforcement to say combine these 2 packages that we separated.
correct,
You made the decision to combine those 2 packages
yes, I made the logical decision, yes,
on your own,
correct,
based on your experience at the time.
yes.
How much experience at the time did you have?
I believe I had 2 years of experience at that point.
So with the 2 years of experience you had, you made the decision without asking anybody else to combine those swabs.
I don't remember if I asked anybody else or not.
But it was your decision to combine the swabs.
Yes,
And now we can't tell whose DNA was on the trigger, can we?
We can tell whose DNA was on the two combined items, not on the trigger by itself, no.
Let me ask my question again. I understand what you're trying to advocate, but let me ask my question again. We can't now tell whose DNA was actually on the trigger, can we?
Correct.
Even though the trigger had 2 swabs on that trigger for DNA, correct?
Yes, however, in my notes, I did not consume all of the evidence.
Okay, but do we know, can you tell us right now whose DNA was on this?
On my testing, no.
Let me finish my question so she can type it down and can you tell this jury right now whose DNA is on the trigger?
No.
Ms. Vida, that's all the questions I have. Thank you.
Redirect.
You were questioned about the summary that you were given prior to being able to work on this case in October 2009, correct?
Correct.
And so if that summary included any sort of story about what happened, that could only include statements that were made prior to then, correct?
Sustained, rephrase.
Is it fair to say that if they give you a story, a narrative of the events, the statements that they relied upon had to have obviously occurred prior to that?
Yes.
All right. So if prior to October 2009 there was a 911 call, could that be therefore included in a summary to you in October of 2009?
Overruled.
Yes.
And if there were an email sent by Mr. Ward in September 2009, could that be included in the summary that's provided to you in October of 2009?
Yes.
If Mr. Ward gives a version of events in 2011, could that be included into your case package summary in October of 2009?
Yes, the requester can include whatever they want in the summary.
I'm asking, can something that happens in 2011, if there's a statement from 2011, can that somehow be included in a summary of events for October of 2009?
No.
Okay. May I approach with 20?
Okay.
Now, maybe it's semantical and lawyer-like, but when you were asked to figure out who pulled the trigger of this weapon, can you demonstrate how to pull the trigger of...
Objection, it misstates my question. I don't want to speak too much, but it misstates my question.
Rephrase the question.
Did you believe your goal was to understand who pulled the trigger of this weapon?
Objection beyond the scope of the process.
Overruled. Go ahead.
Can we approach that?
No. Go ahead.
All right. You remember being asked about some statements you gave and some answers you gave in prior proceedings.
Yes.
All right. Can you demonstrate how to pull the trigger of this weapon without holding the grip?
No.
Okay. Why not?
Because you need to hold the handle to pull the trigger.
Now, realizing that you had a mere 2 years of experience of doing DNA coursework or casework at the time you worked this case, I asked you on direct, was this an independent decision that you had made on your own, or was this common practice to combine the trigger and grip swabs to find who pulled the trigger of a firearm?
I know it wasn't unusual because the file went through review, so 2 additional analysts that had a lot more experience than I would have reviewed the file, and if that was a problem, it would have been pointed out to me, and something would have been done about it if it was wrong.
And now, I believe you testified earlier that it's one swab for the entire gun to find the handler.
Yes.
Now, even with combining the trigger and the grip swabs, can we say that Mrs. Ward's profile was there?
No, no determinations were made.
No other questions? Well, one more question. And was there a major profile there?
Yes.
And whose was that?
K5, James Ward.
Thank you.
All right, may this witness be excused?
Yes, ma'am.
Mr. Ellsworth? All right, thank you. You are free to go. All right, ladies and gentlemen, this brings us to the lunch break. Same rules as always. Have a great lunch. We're going to start back at 1:30, so the deputies will meet you in the courtroom at 1, or in the jury room at 1:15. We'll see you then. Thank you.